So welcome and thank you all for joining for today's presentation, which is CDC's Rural Public Health Science Priorities with Drs. Macarena García and Dr. Kevin Matthews. Today's presentation is brought to you by the Social, Behavioral, and Economic COVID Coordinating Center at ICPSR. This presentation is being recorded and will be shared on ICPSR's YouTube channel. We do welcome your questions. If you want to, please type in your questions at any time using the chat box on the bottom of your Zoom window. There will also be a time for Q&A at the end of the session. Live transcript is available. To show or hide that transcript, click the up arrow on the live transcript button. And with that, I will introduce our speakers and then hand it over to them. So Dr. Macarena García is a senior health scientist at CDC's Office of Rural Health. Before this assignment, Dr. Garcia was on an extended 18-month detail to the Office of the Assistant Secretary of Health, or OASH. She's been the principal investigator on several national studies on preventable premature death among adults in rural America. Before being recruited by OASH, Dr. Garcia served as the CDC Country Director for the Dominican Republic from 2020 to 2022. Dr. Garcia has been scientific lead on rural health at CDC since 2016. Dr. Kevin Matthews has been a health scientist at the CDC since 2015, specializing in rural public health. He was key in establishing the Office of Rural Health in 2023. He's a trained health geographer with a PhD from the University of Iowa and a Master of Science in Geographic Information Sciences from George Mason University. And he has published on many public health topics such as dementia in rural America, rural-urban trends and deaths from COVID-19, and geographic accessibility to healthcare services. His current interest is developing methodological solutions to common problems associated with rural health data. And so with that, Macarena and Kevin, I will turn it over to you.
Thank you. It is a pleasure to be here. Before I start, I just want to get technology out of the way. So I'm going to share my screen, and what I hope you all can tell me is once I share the screen, I can no longer see what is happening with all of your faces. So can you all see my screen? That should be a slide entitled Rural Public Health Science Priorities.
Yep, we can.
Perfect. Do you see my notes or do you just see the slide?
Just the slide.
Perfect. Okay. So thank you for that introduction. That was very, very nice introduction for myself and Dr. Kevin Matthews. Kevin and I have been working together even before the Office of Rural Health was established in 2023. He and I actually came together under the leadership of Dr. Diane Hall, who has been leading the rural health work at CDC since 2016, long before we ever had a rural health office at CDC. So Kevin and I worked very closely during the COVID pandemic, and we actually brought rural into the fold during the COVID response, the CDC response. So this, this is very appropriate because your group here is Social, Behavioral, and Economic COVID Consortium meeting. Although this is not the topic of our presentation today, you will see some of that interwoven. So again, this presentation today is really broad. It is about the rural public health science priorities that we have in our office. As I mentioned, our office was just established in 2023, but we have been doing rural health work at CDC in a coordinated fashion since 2016. However, we have been doing rural health work forever at CDC. It has just not been coordinated. It has been embedded in our programs at the different centers at CDC. Our presentation agenda for today, I'd really like to, talk a little bit about the Office of Rural Health and explain why it was set up, what our objectives are, and what we're currently doing. I also want to share with you the rural scientific resources we have at CDC, which are quite significant. We also will talk about the rural public health science presentation. So we have a lot of that is ongoing. And some topics we will cover today that are thematic in nature are rural-urban differences in preventable premature deaths in the U.S., which is the work that I lead at CDC. We'll also share some information on prevalence of Alzheimer's disease in rural counties, and that is Kevin's work. We'll talk a little bit about CDC-sponsored call for papers on topics related to public health. Kevin will talk about that. We also have rural analysis tools that are currently in development, so we'll both talk a little bit about that, and also how to leverage CDC surveillance systems to conduct rural health research. Just in case, for those who don't know CDC very well, we are very, very large. We are comprised of, at any given time, it changes, but between 13 and 15 offices and centers across mostly Atlanta, but also some in Maryland and DC. So we have a lot of surveillance systems. Prior to COVID, when we had a cataloging activity, we had approximately 260 different surveillance systems under the CDC umbrella. After COVID, of course, that is a much, much larger number. And we will conclude with our science priorities and, of course, some opportunities for collaboration, because once I talk to you about the Office of Rural Health and you see how very, very small we are, we actually do conduct a lot of scientific work, but we do that collaboratively with partners, not just across CDC, but partners across the federal government and also institutions of higher learning. So let's dive into our Office of Rural Health. So we do have a strategic plan. It is online. So for those of you that want to learn more about our office, I recommend that you, visit that plan. But at a high level, our purpose is to improve the health of rural communities by advancing the best rural public health science and practices through a coordinated, transparent, and strategic approach. Our values are based on leadership, on collaboration, which we talk a lot about, on scientific curiosity. We don't know what we don't know, and we want to know more of what we don't know and fill those gaps. Certainly on innovation, as far as scientific innovation. And we also are founded on empowered decision making. And I'll add to that, data-driven decision making. Our priorities are fourfold. One is to advance engagement with partners and community. I would say that is really the number one thing we have been doing ever since we've been established as an office. One of the reasons why the director of our office is not here today is because she is so busy traveling and speaking across the country about our office. So the engagement with partners and communities is pretty significant for our office. The second priority is to strengthen rural public health infrastructure and workforce. So that is very important for us. Number 3 is to advance rural public health science, and that's why Kevin and I are here. We're both part of our science team. And number 4 is to improve rural public health preparedness and response capacity. So this is also very, very important for us. And I mentioned that Kevin and I and Diane Hall were very engaged in this during the COVID response at CDC. Our principles are sixfold. The first one is we really focus on strengths. And what does that mean? We focus on the strengths of rural, not just our own strengths in the office, but the strengths that rural communities bring to the table. We champion the work, the good work that's taking place in rural communities that is very effective, that has impact. We champion that work. We disseminate best practices, not just of the work that we do, but obviously best practices that our partners are doing, as well as community members and community groups are doing. We, of course, collaborate with partners. We would not be able to function the way we do without collaborating with our many partners. And this is, again, from the scientific perspective, we examine variability. And we will talk a little bit more about this, and Kevin has some nice slides on this, but we don't just focus on how is rural different from urban, right? I think there's a lot of literature on that already. What we want to examine is how is rural different from rural in different, geographic places in our country. A rural community, for example, in Maine is very different than a rural community here in Georgia where I live. So we like to examine that variability and understand the distinctions. And we know that there is not a one-size-fits-all intervention for rural communities. And of course, our principles of integration, we want to integrate rural health across CDC programs. So what does that mean? We work with other centers, other offices, and we want to integrate all things rural health. From my perspective in science, we are trying to integrate variables that capture that geographic level of granularity that we need to understand what's going on in rural spaces in, for example, cancer, in chronic health, in unintentional injuries, in the opioid space, in the suicide space. And that requires us to collaborate with all those different centers, all those different programs. And that is very, very important for us and a guiding principle. We have some rural scientific resources at CDC that are not well known. And so we also do a roadshow of these scientific resources because they are very valuable. And we're consistently bringing on new resources. So I'm going to hand it over to Kevin so he can talk a little bit about the cookbook. He will have a few slides that he will be presenting, and we will be tag teaming throughout the presentation. So Kevin, did you want to introduce this topic?
Sure thing. Thanks, Macarena. One of the topic areas that our director, Diane Hall, first discussed with me when I started working with her during the pandemic was many of the missed opportunities for analyses that people in the agency or outside the agency could have done had they had better knowledge and better access to rural variables in CDC data sets. So we have many data sets, many of which actually have either rural variables or have variables from which you can derive a rural classification scheme or a rural classification for use observation. So this idea of the cookbook is filling that gap of making people aware that the data exists and providing a step-by-step process for how to get for how to access the rural variables in a CDC data set. And there's three key components. We're calling this the data catalog. So this is basically the list of data sets with rural variables and some associated metadata with how those rural variables were generated. We have the recipes themselves, either step-by-step instructions for accessing and processing a CD data set with rural variables. And then we have this rural classification decision tool. In our office, one of our mantras is there is no gold standard rural classification scheme. But we know that there are many classification schemes one can choose from. So what we're trying to do is develop a tool that helps analysts choose among the available classification schemes. I have a release date of 2024. I think that the initial catalog will be released around National Rural Health Day in November, and the other components will be released on a rolling basis throughout 2025. Next slide, please. Thank you. So this is the Rural Health Mapping Tool, which is currently resides on the NORC.com or .org website. This tool was developed by NRC during the COVID pandemic, and it was developed primarily to help local public health offices understand will provide vaccine data and mortality data and incidence data related to COVID-19 at the local level. Yeah. Okay, thanks, Megan. Yeah, and so that tool has now, so it's developed for COVID, but now we've developed it further. So we have some If you look on the left over there, we have some health variables that would be, you know, if you do the drop down on that on the button, you would see life expectancy and other variables that I can't think of off the top of my head. So anyways, yeah, I think that's enough on that. Next slide, please.
Yeah, correct me if I'm wrong, Kevin, but I think we have about 19 different variables. Is that right?
That sounds about right. Yes.
Yeah, so very useful tool.
Very useful tool, definitely. Okay, so this is a CDC product called Places, local data for better health. So this is not an Office of Rural Health product. This is a CDC product as a whole. And it's a very powerful data set of estimates for every census tract, every county, every zip code tabulation area, and every census designated place in the United States. There's about 40 health indicators, and these would be chronic disease incidents, health behaviors, and social factors. And there are tools online for interacting with the data, or you can download the data yourself if you're data savvy and operate these variables however you'd like. Yeah, but an extremely powerful data set, and I actually worked on the team that develops this, so be happy to chat with anyone about the way it can be used for rural analysis if anyone likes at a later time. Next slide, please. Okay, so speaking of rural classification schemes, CDC has a rural classification scheme that we developed in-house. It was actually developed by the National Center for Health Statistics, which is a center within CDC. It's called the Urban Rural Classification Scheme for Counties. Most recently updated in 2013, but we are currently doing the 2024 update based on the recent release of the metropolitan designations by the Office of Management and Budget. We'll have that update out. We're calling it the winter season, so sometime straddling 2024-25. Yeah. So yeah, and we're really on one hand, as I noted, there is no gold standard rural classification scheme, but typically in CDC we turn to this one simply because it's our in-house classification scheme. Next slide. Is this me, Macarena?
So I think you can take this one on because the next slide is yours.
Okay, great. So Macarena mentioned at the beginning of her talk that since 2017 there's been a coordinated effort for doing rural public health science in the agency. Prior to that, CDC had been doing rural analyses, but it was really on an ad hoc basis. If someone was interested in rural, then they would do a rural analysis, but there was no intentionality at the agency level for doing that. And that changed. The legend goes, a congressperson, I actually don't know who, took Dr. Friedman aside one day and said, "Hey, what is CDC doing around rural?" And Dr. Friedman didn't have an answer to that question. So he contacted the powers that be within his office, who subsequently contacted Diane Hall, our director, who was designated as the rural point of contact for the agency. And at the same time, actually, I will go to the next slide if you don't mind, Macarena. Yeah.
So
Sort
maybe
of
we'll
out of
backtrack. We can start with
Yeah,
this.
there you go.
Go
Thank you.
back.
You saw where I was going. Okay. So around the same time in 2017, the folks at the MMWR, so this is CDC's in-house reporting system, the mortality and morbidity weekly report, initiated a surveillance series, and we had, I believe it's 17, if you count that, 17 different articles that were published in 2017 on various health topics related to let me rephrase, rural topics related to the following health topics. And we had a pretty wide range of responses. These are all led by authors at CDC. And could one more, next slide, please. And you can really see how it really shifted the trajectory of publications in our office, or in the agency as a whole. So I did a quick literature search on, articles that were published by led by CDC authors from 2013 to 2022 that either mention the word rural or mention the word metro or non-metro or some variation of those terms, and were focused on domestic rural topics. And when you do the tabulation by year, you see in 2013 to 2019 to 2016, we had a fairly flat number of, it was a plateaued number of articles that were being published. And then in 2017, we had this bump to 34. But what's great about this is we can see the impact that those had, because we continued to rise in the number of publications that are going out. We'll get this up to date to reflect after ORH was created, but what I hope to see in the next few years is this trend line increasing over time. Macarena, back 2 slides. Okay, and then so 2024 has been a good year so far in our office. We've had 5 publications come out just in 2024 alone. Macarena is actually going to be talking about this first one, the preventable premature deaths, a little bit later in this talk. And I have some material on this Alzheimer's disease in rural America paper that I'll talk about. Although it says under review, I would like to say that about 20 minutes ago, I got the email that said it's accepted. So ding, ding, ding. Yep. And then some of these other papers that we mentioned below for 2024, it highlights our collaborative nature throughout the agency, where these are either CDC staff or CDC fellows who are leading these papers, but we've had a very strong role in providing the rural subject matter expertise for these particular papers. Okay. Next section.
All right, and Kevin, you kick off the next section as well.
Okay, thank you. So rural public health science. I think one thing that we're trying to hammer home about our office is this idea of rural public health as differentiated from rural healthcare services. And it's not that we don't appreciate the importance of rural healthcare delivery and services. It's that that's not really our lane. So Federal Office of Rural Health Policy, that's their lane. CDC's lane, we're a public health agency. So rural public health is our main focus in the office. And so this table 1, which we did not write, but it does provide a pretty good overview of how we think about rural public health versus rural healthcare. In this case, it says medicine, but I'm sort of using those two interchangeably. And the public health angle's mostly focused on the population. And I think that we're mainly rooted in the public sector, and there's other obvious differences. and I would offer one caveat to this, even though we are focused on rural public health. We certainly understand and do work in the intersection of the rural public health and the rural healthcare space. And that's one of the things that we'll be working on moving forward. Next slide. Okay, so this follows on a theme that Macarena mentioned earlier about the variability and looking at within rural. And what we try to do in our office is learn from the outliers. So these rural surveillance series articles that I'd mentioned earlier, we want to know what's going on in the different areas, in the different rural areas. For example, and where a lot of this is coming from is this idea of positive deviance, where we want to look for the places that we expect to do bad that are actually doing good, and then see what we can learn from those particular areas, and to develop some best practices and for building our evidence base for future policy development. And I think that's all I have to say about this slide. So next slide. Okay. And the idea that I'm trying to express here, I'm going to show I'm going to show two different slides. And one of them is about comparing rural to urban. And the other one is comparing rural to rural. And we're really thinking hard about when it is most appropriate to compare rural to urban and when it is most appropriate to compare rural to rural. So this first slide, it's showing COVID mortality, I think it's mortality, yeah, COVID mortality rates in rural versus urban America in the first, I think it's 6 months of the pandemic. So in this case, okay, so the idea of okay, in this particular case, it's really tells the story to compare the rural epidemiological curve to the urban epidemiological curve. Metro, non-metro is to be more precise. Because we, without that comparison, we have no real baseline for what's going on in the United States. And we wouldn't be able to see that 6 months after the pandemic began, the mortality rates in rural America began to, surpass and began to exceed those rates in the metropolitan America. Okay, so I guess what I'm trying to say here is that when we're making our rural to urban comparisons, to tell the scientific story, we do need to have the comparison to urban to tell the story, as opposed to, next slide, please, rural to rural. There are some times when the rural to urban comparison is not as meaningful as it would be to talk about rural to rural. I think everyone in the room probably understands that for most measures, it's very well documented that for most measures, rural populations tend to have poorer outcomes than urban populations. But that's not because they are sicker, it's because it's a different set of populations, different set of circumstances, different histories, different culture, different everything. And so to make that comparison, which has been done, doesn't really help us understand what's going on in rural. It only helps us it only tells us that there's a difference between rural and urban. So we think that to build better evidence, we need to compare the rural to rural. And then in this case, I'd mentioned this earlier, the forthcoming under review article. So this is the rate of dementia in the United States by state, only showing the rural populations. So this is the rural rates by state. In this case, there is no urban observations at all in any of these maps. And it still tells a compelling story about what's going on in the rural areas of the United States. Next slide. And then I get to stop talking and hand it over to my wonderful colleague, Macarena.
I think this was a great segue,
Yes.
because we're heading into some of the science, and some of the science that has been very recent that we've published. I want to say it was May, if I got that right, was a very large surveillance summary that we published through MMWR. And the title of that was Preventable Premature Deaths from the 5 Leading Causes of Death in Metro and Non-Metro Counties in the U.S. This was looking at a period between 2010 and 2022. Now, this was not novel. We did this we did this for the very first time, I believe, in 2016, then again in 2017, then again in 2019. And now in 2024, we looked at this 12-year period. Now I'm going to give a little teaser. We're now moving into a study that is comparing pre-COVID, post-COVID, and looking at the outcomes, mortality outcomes among, United States, of course, rural, urban, but also disaggregating the data by gender, race, ethnicity, and of course, further geography. So that is to come. But this particular surveillance study is very important for our office because it represents a pretty significant collaboration. Number one, we collaborate with NCHS, who pulls all this very rich data for us and is, basically our methodology guru for this work. I will say that estimating premature deaths, or what we have often called preventable excess deaths, or pre-COVID, it was preventable potentially preventable deaths. It's not easy. There is no gold standard for this type of estimation. And so NCHS actually has a very robust methodology to estimate these numbers that I will not get into here, but it is in the methodology section of our work. But I just want to go into some findings to share with you. These, like I said, this was already published in May of this year. But if you're interested in diving deep into these findings, you can go ahead and look at that. We have lots of data visuals. This was on the news, on ABC News. We had a really very neat data-driven data story that we presented to the media and to the press before this was released. But what does this mean? What did the results tell us? So now, first and foremost, I just want to define premature deaths in the way that we defined it, because in the literature, you will see it defined in many, many different ways, okay? In our analysis, premature deaths were those of, they were age adjusted. It was a measure defined as a death that occurred to a person aged under 80. Now you might say, wow, that's not that young, right? But this age restriction that it's what our threshold is consistent with the average life expectancy for the total US population, which was 79 years in 2010. You may say, why did we choose 2010? Well, that was the first year of our study period. So that's why we chose 2010. There's lots of reasons why we chose not to have a rolling, shifting, average life expectancy, and I can get into that for those who are methodology geeks. I'm happy to do that, but that is how we defined a premature death. So if you look at this figure that I have here, you can see the age groups. This is everybody, not everybody, every death that was accounted for through the National Vital Statistics System for metro, non-metro, everybody between the ages of basically birth and 100 plus. So we removed people who died at year or age 80 and above. Okay, these deaths were outside of the average US life expectancy for our study, and so those were not included. So we're really, and this study was for adults, so we're including the ages of 18 through 79, right? So anybody who died before the age of life expectancy was included in this study. Now, I will talk a little bit about how we estimate this because I think it's important. People will want to know, well, how do you estimate these? So I'll give a very high level explanation of our estimation. But what we use is a benchmark method. And this has been used by NCHS and our team because we've been working collaboratively with NCHS since 2014 on these studies. And so that benchmark method, it can seem pretty simple outright, but if you read our methodology, you'll see it's a bit complex. But what we basically do, and this is just an example, this is a heart disease example because these benchmarks that we establish are specific to each condition. And we're looking at the 5 leading causes of death in this work. I will say caveat, and I think it may be on my next slide, we excluded COVID because we're looking at a historical period. And so COVID obviously was introduced in 2020. So we excluded COVID as a leading cause, although of course it was and continues to be a leading cause of death. The premature deaths for COVID are also because it's an infectious disease that would be calculated and estimated in a different way than the way that we do this here. So we basically take the 3 states with the lowest age-adjusted death rate, and this is for heart disease, and this is an example for 2021. We would be using the data from 2010, and actually it's the 3 years before 2010 because we average it to a 3-year period just to have a very conservative number. But just for example's sake, for heart disease in 2021, the 3 states that had the lowest age-adjusted death rates for heart disease were Utah, Minnesota, and Colorado, okay? If you look, so they're highlighted on the map there, but if you look at the bottom figure, which is a lollipop chart, you'll see those states at the far left, they're highlighted. When you average those 3, we get the benchmark, okay? And so that is what we use. That is our benchmark. So you could see that dotted line there in like teal color. That is our benchmark. And then what we're saying is if every state in our country had that benchmark level, how many deaths would we have seen from heart disease in that year? Okay, so that's how the benchmark method works. Like I mentioned, there's no gold standard. And maybe I'll just go back just a sec because there's usually a slide that I like to include that shows us how we're calculating it. So for instance, I'm going to give you an example. You look at Mississippi on the far right, it's very obvious that they're above the benchmark, probably by 3-fold, maybe more. So that means that Mississippi had many, many, many more deaths than the benchmark. So when we take the benchmark and we calculate how many people we expected to die prematurely under the age of 80, in each state based on their state population, and then we look at the actual number of people who died age 79 and under for heart disease in that year in that state, we see a big difference between the benchmark and what actually happened. And that difference is what we classify as those were all premature deaths, okay? Because if, for instance, Mississippi was performing as good as the states with the 3 states with the lowest age-adjusted death rates, then we would have seen an outcome that was very different. And then we do some additional analysis and we get a percentage. And we say X percentage of deaths were potentially preventable or premature. Okay, so that's how that works. A little complicated. I'm oversimplifying, but I just want to make sure that folks understand where the data is coming from, because now here we are presenting proportions. Okay, so that's how we calculated the proportions, is the methodology I just described. So what do we have in this figure? So these are preventable deaths, okay, and their proportion. This is the proportion of deaths that could have been preventable or were premature. And you can see this, rural counties are represented in purple, and that line is at the top for all of these conditions. And urban counties are represented in gold, and that is at the, the line at the bottom, which represents a lower proportion of preventable deaths. What I love to show on this particular figure is that shaded area, because that shaded area represents what? It represents disparity, okay? In cancer, that disparity was more narrow in 2010, but it started increasing. Although those trends are going in the right direction for both rural and urban counties, that disparity is still widening, okay, over time. And that's because in urban counties, they did a lot better in eliminating these premature deaths. And in urban counties, it's taking a bit longer, okay? For chronic lower respiratory disease, CLRD, you could see it is very wide and just getting wider and wider. Now, I just want you to know in this study, we do provide reasons for why we're seeing this, okay? So our office, I'm the lead author on this work, but I work with SMEs in chronic, in unintentional injury, and those SMEs analyze this work and dig into the data and say, potentially, this is why we're seeing it this way. The literature says this is why we are seeing this. Okay, so that is all in the surveillance summary for those who want to see more. So again, I'm not going to drill down, for all of these. For those interested, the data is available. We have lots of very nice graphics and data stories. But what I want to show you next is, now Kevin and I talked about the variability. And look what happens when we start distilling this data by the actual county categories that are finer, right? That are much more granular. Kevin mentioned the NCHS urban rural classification scheme for counties. This is it, okay? We applied that scheme. The previous slide was the same scheme, but the categories were collapsed into two. In this slide, you're seeing all of those granular, the 6 granular categories presented, okay? And what does this show? Very, very quickly, without having to drill down into what each of these little spaghetti lines are showing, we can see that the purple color, the deeper purple color, is at the top, and that is the most rural of counties in our country. And the deepest gold colors, the lightest gold colors, as we move down all the way to the bottom of the spaghetti lines, are the most urban. Okay, it could take us easily an hour to dissect this. And this is what we do in the paper. Okay, just so you know, it is all in there. But what I really want to show is not necessarily the findings here, but how significant it is to actually take the time to do this analysis. Because now we can really see in some of these conditions, we can see that, the issue perhaps is not in the most rural, but in the micropolitan. For instance, just something, again, this is less rural and more urban. If you look at some of the findings, for instance, in stroke and unintentional injury, it's really the large fringe metro and the medium metro, which to us, if you want to just in layman's terminology, that would be the suburbs. So it's not necessarily that the problems or the highest proportion of preventable premature deaths is happening in rural areas. In some of these places, it's happening in our suburbs, right? And that's important to know too. And we wouldn't get to that level of granularity and those results if we didn't conduct this type of analysis. So this is very, very powerful. Now, for those who, again, are interested in this work, we have an interactive data visual, and it is in Tableau public, and you can access this. So if you're any specific state and you're interested in seeing what your results were for this specific work, you can select the cause of death. This is just a static image, but you can select the cause of death, and you'll see the 5 leading causes that we analyze, and you can select your county categorization. This just allows for the 2 larger categories, urban and rural. Once you start getting into the non-core counties, you start getting numbers or actual raw death counts that are less than 10. And so those are suppressed, which is why we have to, at least for mapping purposes, why we have to use those 2 larger county categories.
Macarena, sorry to interrupt, but we are coming close to time. And so I just wanted to say that we will have to, unfortunately, wrap up here in the next minute or so.
Yes, we only have 1 more slide to go.
Okay, perfect. Sorry to interrupt.
No, you're good. You're good. Okay, so our science priorities and opportunities for collaboration. This is my last slide. And these are our scientific priorities today. We reassess them every year, but currently what we're prioritizing is the leading causes of death, which obviously you've seen here. We're also prioritizing women's health, and I lead that effort. We are focusing on maternal mortality as well as maternal and child health outcomes. And we do this not just within CDC, but we have partners, federal partners outside of CDC that we're collaborating with. We're looking at obstetric care facility closures within that higher level category. Other priorities are racial and ethnic disparities in health outcomes, which I mentioned a bit earlier. Broadband connectivity and telehealth is something that has been a very big priority for us. Mental health and behavioral health, as well as aging. And I think Kevin just, you saw some of his work on dementia and Alzheimer's. So that concludes our presentation. You can learn a lot more about all of our work at our rural health website. And that is also where you can connect with us. So I'll stop there. And I know you all, we probably still have a little bit of time for Q&A.
Perfect. Well, thank you guys so much. It looks like we have a lot of comments coming in about people excited about this. And we already have somebody with their hand raised. Dawn, if you want to unmute yourself and ask your question.
Thanks. This is great. Congratulations on a fine job. It's great to hear your thoughts. First of all, on your last slide, I just wanted to tell you that I would love to see you emphasize concerns about sexual and gender minorities in rural places, and potentially poverty and its intersectionality with rural residents. Just kind of throwing that out there. And the next more meaty comment is for Kevin. I'm a statistician, by the way. So, of course, you could probably teach the rest of us about the fact that small samples are highly variable. So when you look at small communities and you see some that are brilliantly successful, of course, you know that it could be due to the inherent variability of small samples. Of course, it is exciting to and I remember the Bright Lights study in Appalachia. Do you remember that? They did kind of the same strategy of looking at communities and trying to see what they had in common. I think that something that can be really helpful is to try and follow on that type of analysis with the type of research that NIH often, relies on, which is doing a larger clinical study prospectively, where communities are potentially randomly assigned, maybe like in a stepped wedge manner, and where we really sort of look at not just what works, but how it works and what key community strengths are necessary to make it work. So what do you think about that?
Well, I just say, for sake of time, you're already on my list of people. We've met before.
You're on my list. I'm on your list, Kevin. Wow.
Oh yeah.
That good?
Yep. I know
the
you.
naughty list or the nice list?
The nice list, and we're gonna tap into you for some resources we're developing, and maybe we could chat more then.
'All right. Thanks.
Yeah. Yep.
All right, I think we have time for maybe one more question. If no one else will go, I would ask just, if you guys could talk a little bit more about, some of the types of collaborations that, you would be open to having with researchers, particularly in academia, and kind of how you generally approach that.
Kevin, did you want me to take that on?
I'll just throw out one, which is like, I think that was mentioned that I'm interested in developing resources for dealing with these rural small number problems and other data problems with the rural. If anyone has any interest in talking to me about that, I'm, that's my bailiwick at the moment. So I'll drop my email in the chat, and Macarena.
Yeah, so when our scientific priorities align, a lot of what we do with other federal partners as well as institutes or institutions of higher learning is we collaborate, we provide our rural health expertise in whatever fashion makes most sense for the project, right? So the way that it has worked is people come to us and say, we have this project X, Y, and Z. We're missing this component. We really would need your expertise to, contribute to this element. A good example I'll give you is someone came to us and said, we are actually going to implement 3 different public health programs in these 3 different rural communities. We don't really know how to evaluate this or assess the impact of this. So we're coming in with some evaluation best practices, some strategic direction on that. For science specifically, which is what Kevin and I do, we collaborate as authors, as co-authors. We bring in our expertise. We will bring in data sources if we need to also advise on methodologies, right? We can do that as well. So it can look very differently depending on the project and the need. All it takes is reaching out to us and seeing what our capacity is and whether those priorities align. And we are every day actually growing bigger and bringing on additional resources, both human and otherwise. So we will have opportunities for further collaboration.
Perfect. Well, thank you both so much. I think we're unfortunately just a little bit over time, but I think that, again, goes to show, how much great work you guys are doing. So really appreciate you guys being willing to come and share this with us. I hope you will also, think of us, if you have specific questions on who you might be interested in connecting with, particularly, specific topic areas, if we can play matchmaker that way, the coordinating center is happy to do that. So thank you both again so much, and thank you all for joining, and we'll see you next time.
Wonderful. Thank you for having us.